Hey everybody. So according to my badge, we're here to talk about invasive fungal infections, diagnostic advances, and stewardship implications. So it looks like we're all in the right room. If not, you do have time to leave without me judging you. So yeah, Mike Czapka from University of Chicago. Happy to be here. So these are my disclosures. I'm not going to be talking about any investigational drugs during the talk, but if you want to talk to me about those afterwards or in the Q&A, feel free. And then let's see, so a little bit about me. So I primarily work with severely immunocompromised patients on our inpatient service, also see that population in clinic, study complication cell therapy, and then also work in the space of diagnostic stewardship and clinical trials. Um, I will, as we mentioned AI earlier in the day, I will confess that some of my images are AI generated, which I think is the best use that I've found for AI so far. My slides are all human generated, which means that some of them may contain human errors. But a little bit about what we'll be talking about today. So the talk about 30 to 50% of the way through is going to focus on diagnostics for fungal infections. That being said, fungal infections are complicated. And if you're talking about stewardship, you need to talk about pharmacology, you need to talk about epidemiology for these populations who are at risk. And so we do need to cover a fair amount of background in order to sort of make sense of the diagnostic portion of the talk and diagnostic stewardship considerations and therapeutic stewardship considerations that are sort of related to this. So I'm curious for people in this room, who is primarily a clinically oriented person, sort of regardless of degree, caring for transplant immunocompromised populations? Okay, so we got a few. And then how about general infectious disease clinical folks? Okay, good amount. Infection preventionists, good amount as well. Pharmacy? Fabulous. Epidemiology of public health. Okay, this is a pretty good mix. I love it. And then health service researchers, nursing. Fabulous. And then anyone in primary care or other specialties? Okay, all right, very good. Good mix. So hopefully no one is going to be running me out of the room with pitchforks, but we'll see how controversial those slides get. So we're going to start by talking about some background, which is really medically important fungi and how we first hear about these things from the lab with sort of conventional diagnostics, meaning like a fungal smear or culture result. So we break these down into yeasts, molds, with a U if you're fancy or British, and dematiaceous or pigmented fungi. So yeasts, if they're described as having pseudohyphae, that's generally going to be Candida. And so that's one of the most medically important fungal pathogens that really anyone can get. There's some more interesting yeasts like Cryptococcus, and then dimorphics or endemics like Histoblasto here in Chicago we see a lot of, or Cocci, Penicillium marneffii, et cetera. For molds or filamentous fungus, those are things like Aspergillus, agents of mucormycosis, Fusarium, Acetosporium, et cetera, et cetera. And then dematiaceous or pigmented fungi, those are fungi with melanized cell walls like Alternaria phylophora, Bipolaris, et cetera. So when we get a fungal smear back from the lab, this is already a stewardship opportunity. I'm going to be dropping in stewardship opportunities throughout the slides because this is, of course, a stewardship conference. But, we get a fair number of calls just from primary services regarding the fungal smear, the fungal stain, before even the pathogen is identified. And so, for instance, we get a lot of calls about yeast with pseudohyphae in a urine culture or respiratory culture. Most of the time, that's going to be fake news. There are exceptions to that, but most of the time, that's fake news. And so that in itself, knowing the difference about where these things are typically pathogens, about what site, about what type of host, can help you sort of give correct empiric therapy or discontinue inappropriate therapy or prevent an inappropriate antifungal from being started if there's a high concern for contamination or colonization like Candida in respiratory culture or urine culture. Okay. Another thing that we have to cover in this talk is just kind of generally antifungal spectrum of activity. The reason to talk about this is, not every center has the ability to do this in-house. Sometimes these are send-outs that can take a long time to come back, if you get them back at all. For some of these, we generally don't do antifungal susceptibility testing towards the bottom of the list. And then complicating things for many of these, for some of the, particularly the newer antifungals, you may not actually get a interpretation of that MIC back as susceptible or resistant. So you have to go into the literature to find out what you feel comfortable with numbers wise. So that's another sort of complexity. But basically, you kind of, when you're dealing with these infections, you more or less have to have this type of table memorized in your head to make correct empiric choices because of delays with getting antifungal susceptibility testing back. So what can we sort of glean pattern-wise? So the top of the table is Canada, middle of the table is mold, bottom of the table are yeasts slash endemics. Let's look at the echinocandins on the right side there. So as you can see, echinocandins like mycofungin, excellent activity against most species of Canada. A little bit of activity against Aspergillus, but it isn't first-line therapy. But if you look at the echinocandin activity against dimorphics or molds, there's really nothing there. And so we very frequently, in my experience, get calls from the ICU or other services saying, we're concerned that our patient has fungal pneumonia. Please approve mycofungin. And so looking at this table, Canada is not going to be the cause of fungal pneumonia. It's all the things on the bottom of the table for which mycofungin doesn't have activity. So again, when you think about this susceptibility table, this is a way to respond to some of these antibiotic approvals or stewardship requests. The other thing that I'll mention here, it's important to note, for fluconazole, has great activity against most species of Candida, but sometimes Candida auris, sometimes Candida glabrata, definitely Candida krusei. You can see some holes in that activity though. We generally, for holding the antibiotic stewardship pager, will be aware of some of these patterns of susceptibility based on species, but that isn't the case for many of the folks who are calling us or who are reviewing these lab results primarily. And so something that you can consider doing at your institutions as sort of a stewardship initiative is, while you're waiting for antifungal susceptibility testing to come back, you can consider something like we've done, which is putting a little note from the microbiology lab while we're waiting for that testing to come back, which says something along the lines of Candida krusei is generally considered fluke resistant, or Candida auris, fluconazole is not recommended empiric therapy to sort of prevent some errors from happening. So those are just some ideas there. Okay. So this is a little bit controversial, and so for the pharmacists in the room, please don't run me out with pitchforks. Essentially, with antifungals, distribution to all tissues or all spaces in the body is not equivalent. And so some spaces of particular interest are the urine, concentrating in the urine and the bladder, the eye, as well as the brain. There are, case reports and exceptions to sort of this table, but just knowing that those considerations are there for certain antifungals and certain sites of infection is important. It can also impact how you do stewardship. So let me give you an example. Okay, so I have, let's say, a liver kidney transplant recipient. So the liver and kidney transplant teams are never going to want to give their liver and kidney transplant recipients something that will harm those grafts if they can avoid it. Okay. That being said, they're also very concerned about undertreating things that are in a urine culture, sometimes regardless of whether or not a patient has symptoms and regardless of how far they are from transplant. So imagine you get a call for someone like this saying we found Candida krusei in the urine and we would like to treat it with mycofungin. Or we would like to treat it in general. So from the last slide, you know that Candida krusei is fluke resistant, so fluke's going to be out. But they wanted micafungin. So the problem with micafungin here is if the patient is assuming that the patient actually has an infection, which is sort of its own conversation. Micafungin is not going to concentrate well in the urine. And so if you're trying to get a good concentration of an antifungal in the urine, you're probably going to be giving old school amphotericin deoxycholate, or adding flucytosine plus another antifungal as sort of a combination regimen, for instance. And so old school amphotericin deoxycholate or flucytosine can have important impacts on kidney function or liver function. And so when you explain that to the person on the other end of the phone, the way that they weigh risk versus benefit changes and hopefully goes in the right direction as far as being stewardly with not treating an asymptomatic candiduria, for instance. So that's just kind of an idea of stewardship with antifungals. Okay. Another background piece of information to talk about is, I'll say, host-centric decision making. There's other ways that you could sort of refer to this, but not every patient is equally susceptible to every fungal infection. And so this is really important for diagnostic stewardship, sending a test that makes sense for the patient that's in front of you, and then, of course, therapeutic stewardship after that. So this is very broad strokes, but really everyone has a risk of Candida, right? So many of us have had thrush after taking an antibiotic or vaginal yeast infection, et cetera. So there's some risk of Candida for everyone. Invasive candidiasis we'll get into more in a second. But for people who have disordered neutrophils, meaning that they have a quantitative or a qualitative defect in their neutrophils, and there are some examples up there, that is risk factor for mold infections like Aspergillus, Mucor, et cetera. And then if you have a T cell disorder, so again, you don't have enough T cells or they are not functional, things like histoplasmosis, pneumocystosis, et cetera, are concerns. That being said, what I find most often these days is that many of our patients have mixed immunologic deficits. So if you think about someone who has a stem cell transplant and they're getting graft versus host disease prophylaxis, or if you think about someone with an organ transplant, multiple lines of the immune system are down. And so it's generally speaking, not this clean. And there's a little bit of a mixed immune deficit. And so risk for different types of fungal infections. But, okay. So we'll speak a little bit more about people who are at risk for certain types of fungal infections. So there are research criteria published for how you define an invasive fungal infection. So there's a category of proven invasive fungal infection, okay? And so that's when basically you have histopathologic confirmation of tissue invasion with fungus. So that means that you essentially need tissue, which means that you need a biopsy. Many patients cannot get biopsies for various reasons. That procedure might not be available. They might have a disorder of hemostasis. They might be unstable, et cetera, so on and so forth. So in these guidelines, there's also a category of probable invasive fungal infections. And so to define a probable invasive fungal infection, you need a few different things. One, you need a host factor. The host factors are on the board here, meaning something in the medical history or in the medications that confers a risk for these types of fungal infections. Two, you need a clinical factor. Generally, that's going to be imaging related, characteristic findings on chest imaging, for instance, of fungal pneumonia. And then you need a microbiologic factor, which means something from the lab that suggests fungal infection. Okay, and we'll get into that more towards the middle of the talk. All right. So on the left side is probable invasive pulmonary mold disease, or mold diseases in general. And then on the right side, probable invasive candidiasis in the ICU. So these are the host factors. So what types of things put you at risk for an invasive mold infection like pulmonary aspergillosis, invasive pulmonary aspergillosis? So severe neutropenia, heme malignancies, allostem cell, organ transplantation, high dose steroids, different types of biologic immunosuppressive or other immunosuppressive medication listed there, BTK inhibitors, people with a primary immunodeficiency like CGD, and then graft versus host, of course, that kind of falls into allo stem cell. So these are severely immunocompromised patients, okay? Now, switching to the right side for probable invasive candidiasis in the ICU, what are host factors that are associated with that? So you can see that there's some similarities there, meaning stem cell, organ transplant, steroid, neutropenia, but there's also some more relatively vanilla things that everyone sees if you work in an inpatient setting, like recent abdominal surgery, any type of chemotherapy, ascites, mucositis, pancreatitis, presence of a central line for whatever reason, and then isolating Candida from multiple sites. Those are considered host factors for risk for invasive candidiasis. So going into this a little bit more, not really anyone can get like an endemic mycosis, like histo or blasto. So we see a lot of this here in hosts who are mostly normal, and they don't need to be severely immunocompromised. So that's just something to recall as well. The other thing is that there are non-invasive forms of fungal infections. And so those are things like instead of someone who's severely immunocompromised, it might be someone with a chronic lung disease who has allergic bronchopulmonary aspergillosis, chronic pulmonary aspergillosis, aspergilloma. The way that you test for those things and the way that you treat those things is different than for invasive pulmonary aspergillosis. And so that takes you down a different diagnostic pathway. And then, of course, like we mentioned earlier, mucocutaneous candidiasis, thrush, vaginal yeast infections is common in just the general population. So not everyone with a fungal infection is severely immunocompromised. So this, the fungal diagnostics that we talk about half of them will apply to sort of a general population, more or less. So, when you take all this into account, you have to, taking into account drug distribution, antifungal susceptibility, memorizing sort of empiric regimens, looking at the hosts, those types of things. It's complicated, and this is information that we have access to as part of our training. But generally speaking, a lot of primary services in the facility, will not have this kind of readily available at the top of their mind. And so this is really an opportunity for us who practice in infectious disease and who work in the stewardship realm to teach and to use sort of our position and our knowledge to essentially do antifungal stewardship. Part of this as well is explaining risks and benefits to primary providers about what are the implications of starting amphotericin, what are the implications of starting voriconazole, what's the risk versus benefit ratio based on sort of our experience and our knowledge, and sort of using that as a way to do stewardship as well. Okay, so we're going to switch into talking about antifungal. Sorry, it should just say fungal diagnostics. Culture and histopathology for fungal infections have been around for a good long time now. Over the past few decades, there's been an explosion of antibody-based tests for fungal infections, or serologies, as well as antigen-based tests. We'll touch on antigen-based tests in the talk. And then, more recently, we're seeing more and more and more individual PCRs for different types of fungus, as well as panels for different types of fungal infections that are PCR-based. And sort of the most recent development in fungal diagnostics, from my perspective, is sequencing. So we'll go there during the talk and go through some of these topics. And so despite all the progress that's been made, it's important to realize that, there's no such thing as a perfect test. And so even though we are increasing sensitivity with some of these developments in medical science, you still have to worry about false positives and false negatives. And the more sensitive your test is, obviously you're going to be more concerned about false positives. And so as sort of a stewardship opportunity from a diagnostic and therapeutic perspective, you want to make sure that you're sending the right test for the right patient at the right time from the right source and providing the right interpretation and we'll get into this over the next few slides. But if you send an expensive new advanced test for mucormycosis on someone who has no risk of mucormycosis, they're probably going to get a drug that they don't need, or an unnecessary consult, or unnecessary imaging, if there's that false positive result in that case. So, okay. So why are we talking about diagnostic-driven antifungal stewardship? So this is from a review article looking at this topic in general, and it's been shown that these types of interventions have led to reduced antifungal consumption, reduced antifungal costs, improvement in mortality-related outcomes, and decreased length of stay, as well as decreased length of empiric therapy. So these are all really important metrics that I think a lot of stakeholders in the hospital systems and various facilities would find important. So this is a reason to sort of pursue this type of work. Okay. So we're going to start off by talking about Canada, and for a few slides, the diagnostics for Canada. So Canada is a problem. Generally for most types of bacteria, when you do a blood culture, they'll grow out in 1 to 3 days. Canada may grow out on day 5, or it may grow out after the culture has been thrown away, theoretically. There's sort of an often quoted collection of autopsy studies, unfortunately, that show for invasive candidiasis. And so that's thinking about candidemia, but also like a visceral abscess with Candida, for instance, or peritonitis, that blood culture sensitivity for detecting that may be as low as 50%. And again, the diagnosis is being established at autopsy. So that's a concern. It's a pretty big concern if you're missing half of these. So, and the reason it's a concern is that for patients who are critically ill, which is not uncommon for patients who develop invasive candidiasis or who are immunocompromised, these infections can be life-threatening. And so the quicker that you can establish a diagnosis and get someone on the right therapy, the better. In addition, the quicker that you can exclude a diagnosis and get someone off of therapy which is not indicated, also the better. So how do we do that? So I think some people may groan at this. I have a love-hate relationship with this test, as I'm sure many of you do. So we're going to talk about the serum 1,3-beta-D-glucan, trade name Fungitel. So this is a blood test that detects a wide range of yeasts, including Candida, molds, dimorphids, etc. You can see in the lovely little figure there on the bottom left hand that it's a cell wall component of a lot of different fungi there. Some exceptions to this test: it is not detecting mucor, cryptoblasto yeast phase. Again, that has to do with the components of the cell wall. And one of the sort of letdowns for this, despite detecting a wide range of fungal infections, is that false positives are pretty frequent. And the other thing I'll say is that it's a semi-quantitative result, meaning you may get a result that's anywhere back from 65 to over 500. And you have to figure out what to do with that when you get it back. So some of the things that we see very frequently as a cause of false positive for the beta-D-glucan are a recent receipt of IVIG, as well as albumin, and then there's some other considerations there. So as a stewardship opportunity for this test from a diagnostic perspective, you could consider putting ordering restrictions in place. I know that at some places this is restricted to the infectious disease or antibiotic stewardship service to give permission to order. You could also kind of consider putting restrictions in place of not sending this test soon after IVIG or albumin is administered. And then from sort of a therapeutic or pharmaceutical stewardship opportunity in response to this test result, if you get like a known false positive back, which I would say is something that's happened within a few days of IVIG or albumin, you probably want to hold off on escalating your antifungals or starting antifungals just for that result. And then we'll talk a little bit about how this helps with coming off of antifungals in the next few slides. We'll just briefly discuss the T2 Candida panel. So this is sort of a different method. So this is detecting Candida species from whole blood in as short as a few hours, and it does not rely on having growth in a blood culture first. Again, we've just spoken about some of the issues with blood cultures and detecting sort of more deep-seated Candida infections. And so what happens here, cells get lysed, they do PCR, and there's a magnetic resonance instrument that picks up the amplification. It doesn't detect all species of Candida, which is not fabulous, but it detects many medically important species of Candida. And so one of the things that I'll say is as I was preparing this talk, I was a little bit disappointed to see news that I think this company may be liquidated as of this year. I don't know if they're selling the rights to this test to someone else, but there are micro labs, around the United States that have the equipment there. I don't know if they still need materials or not to run the test, but presumably there will still be some availability for this test in some centers. So let's talk about operating, performance characteristics for these tests for Canada. So when I think about stewardship and test performance, what I think about first is, really negative predictive value. So does a negative test exclude this infection? Can I come off of the antifungal? And so, and the bottom blue box there, this is essentially all the way down to the bottom is the last value at the bottom is a negative predictive value for essentially diagnosing symptomatic patients with invasive candidiasis where they have a suspected Candida infection and assuming 30% prevalence in this article. So as you can see, the beta-D-glucan is about 90% negative predictive value, which is pretty good. T2 Candida panel in this one was about 96%, which is even better. As you can see, there's also other ways to diagnose invasive candidiasis with the straight PCR or with mannan anti-mannan, that's an antibody. And but the performance characteristics there are not as good, and I do not use those personally. So talking about the T2 Candida panel, just briefly again, there's just one slide on this. For patients whose invasive candidiasis was diagnosed and treated based on that panel versus conventional blood culture, you can see that there's a difference here with respect to mortality as well as complications of infection, which are things like metastatic foci of infection that have developed elsewhere in the body, which the authors attributed to making a diagnosis and changing therapy or starting therapy earlier. Okay. So for invasive candidiasis and these non-culture-based tests like the glucan or the T2 panel, considering that the negative predictive value of these tests are 90 to 96%, if the only thing that you're concerned about fungus-wise in the patient in front of you is Candida, it would not be unreasonable to de-escalate an antifungal if one has been started empirically in response to a totally negative fungitel or T2 panel given those operating characteristics. And so for many patients who are not severely immunocompromised, that will be the case. If you have a patient who is severely immunocompromised, you might be worried about other types of fungal infections, and we'll kind of get into that later where other testing may be required. And again, I would just caution interpretation of positive fungitel results. It's just with the amount of false positives that we deal with from other therapies that patients frequently receive in the hospital, like albumin or IVIG, et cetera. So now we'll talk about the galactomannan, also known as the Aspergillus antigen. So this is also a cell wall component like the glucan. And you can see in the figure there on the right that Aspergillus fumigatus has that, but Pneumocystis and Candida does not. There is still some cross-reactivity with the galactomannan with typically commensal organisms like Penicillium and Paecilomyces, so that's benign. But there's also cross-reactivity with histoplasma, which is a real pathogen and a cause for concern. So this is available by blood or by BAL, and sometimes you're able to get it on other fluids as well. There are some false positives with this, with plasma light, for instance, but we don't see this as much of an issue as with the false positive rate with the glucan. So as I mentioned in the last few slides, the glucan can pick up Aspergillus, and the galactomannan can also pick up Aspergillus, given those are both components of the cell wall. And so again, looking at the negative predictive value here, you're for either of those, for Aspergillus infection, not Candida infection, you're looking at 87 to 91%, which is decent. But, and I should say this is from blood in both instances here. But for something as significant as Aspergillus infection, this can be life-threatening in someone who's severely immunocompromised. And so you might want a little bit of a little bit better performance characteristic. So one of the other issues with the tests that I've mentioned is that a lot of the data with fungal diagnostics has been done or has been generated in patients who are not actually taking antifungal prophylaxis. And that is a problem because I don't know about your hospital, but I think in many hospitals around the United States, patients who are getting chemotherapy, who are getting stem cell transplants, who are getting organ transplants, are getting antifungal prophylaxis, sometimes for prolonged periods. And so the issue with that is that antifungal prophylaxis may actually decrease the sensitivity of these sort of conventional antigen-based tests that we've just covered. So that's really tricky, right? So let's imagine that you have someone who is taking posaconazole continuously, who has AML, and it's at a therapeutic level, and they come in with a bunch of lung nodules. It could be that it's not a fungal infection. It could be a drug-resistant fungal infection, like drug-resistant aspergillosis. And so if you can't rely on the antigen tests that I've just mentioned, you're going to need something else to make that diagnosis. And this patient may not be stable enough, or they may not have enough platelets to get a biopsy to sort of prove an invasive fungal infection. So we'll talk about how we get around those issues with sensitivity in patients who are receiving antifungal prophylaxis over the next few slides with some newer diagnostics. The other thing, again, just to keep harshing on this, is one of the problems with these antigen-based tests is cross-reactivity. So if you have a positive beta-D-glucan, it could be that the patient has invasive candidiasis. It could be that the patient has pneumocystis. It could be that they have aspergillus. It could be that they have histoplasma. It could be something else entirely. And, the empiric treatment for each of those things, pretty different. So once you get a positive Fungitel back, you still need to do additional work to really prove what it is you're treating and put the patient on the right therapy. So how do we do that? How do we parse that out about what fungus is causing an elevated Fungitel, for instance? And so we'll get into that over the next few slides with some newer tests. Okay. So as I've said earlier, we're seeing more and more and more PCR-based testing for fungal infections. So there is now a PCR for Aspergillus that you can send from the blood or BAL. It's now been included as a microbiologic criteria for this concept of probable invasive fungal infection. And so that can provide some reassurance. We'll talk about performance characteristics on the next slide. And with that test, it's not all the tests and all the platforms are created the same. So for some platforms for the Aspergillus PCR, you may be able to speciate that out. Okay. And then also potentially detect resistance. So if you're treating someone for a breakthrough fungal infection and you think it's a drug-resistant aspergillosis, you start them on amphotericin, let's say, but then the species comes back as Aspergillus terreus, because that's drug-resistant for amphotericin, you're probably going to make another move with that. So that's a potential benefit there. And then these are not felt to be as impacted by antifungals as the antigen-based testing, so that's another benefit. And there's also the pneumocystis PCR that's available through BAL, which I found very helpful in the last few years. And yeah, and I think there's still an issue with these tests because they're so sensitive. Sometimes we do pick up colonization or false positives when they're being sent for sort of the wrong reasons in the wrong patient. So the performance of the Aspergillus PCR is better from the BAL than it is from the blood, but still not perfect. However, if you combine an Aspergillus antigen with PCR, you're getting a negative predictive value, according to this paper, of over 95%, which is pretty good, I think, to exclude Aspergillus as a contributor for the patient in front of you. So combining different diagnostic methodologies can sort of get around some of the imperfect operating characteristics of the individual tests. Similarly, PCR for Mucor is now available. It is better from BAL, like everything else. A stewardship intervention that you can offer if this came back negative. Perhaps you thought that the patient had pulmonary mucormycosis and you put them on amphotericin. Given the operating characteristics here, it wouldn't be unreasonable to de-escalate off of amphotericin for that scenario. So, and then I'll talk a little bit here. I think I've got about 10 minutes left about metagenomic next generation sequencing for microbial cell-free DNA. Rolls right off the tongue. Also known as shotgun sequencing. The lab that's most famous for this is the Carius test. I'm not sponsored by them. And essentially what happens here is you get generally a blood sample. There's going to be human reads and human DNA and microbial DNA if there's an infection in that sample. It's all chopped up at the molecular level, gets labeled. They sequence everything everywhere all at once in that tube. And then through bioinformatics approach, things that look like human reads are subtracted out, and then overlapping microbial reads are sort of assembled, candidate organisms are assembled through bioinformatics, and then compared to a database of essentially known microbial DNA sequences, and then you get a report. This is the best use of AI that I've ever found, is this mushroom cowboy. Okay, I love this. So I included him, and he's adorable, because sequencing is, I think, the new frontier for fungal diagnostics and diagnosis of opportunistic infections in general, but it's also kind of the Wild West. I mean, now there's been sort of an explosion of this at different labs, and you can do BAL, CSF, whole blood. You can do all DNA-based infections, all DNA and RNA-based infections. You can do more limited sets of things that are known to cause pulmonary infections or atypical pulmonary infections. And there's some, there's potential here. So you can rapidly and broadly test for infections, not just one fungus and not just fungal infections, but everything, more or less. You don't always need an invasive procedure, like if you're sending it from blood. Doesn't rely on you thinking about some rare diagnosis because it's sort of agnostic to that. And for patients who are on fungal prophylaxis, those antigen-based tests may be falsely negative, or for severely immunocompromised patients who may not be able to mount an immune response to have a positive fungal serology, for instance. This is a way to get around those issues by detecting the DNA. So what are some bad parts about sequencing? There's a lot. So many labs will not detect RNA-based viruses, which, depending on your syndrome, could be a really large consideration. You can get false positives from sampling a non-sterile site, or skin contamination, or gut translocation. You can pick up subclinical reactivation of herpes viruses, which we see all the time. And then, you can't really detect a non-infectious condition with this. So it's not going to tell you if your patient actually has ankylosing or DAH. Okay. It's only going to pick up what's there. The other complicating factor is when you get these back, sometimes you get back multiple hits, meaning it might say, we found CMV, we found Aspergillus, we found E. coli, and Enterobacter. And so you still need to know what the clinical syndrome is and which one of those hits is going to match up with that clinical syndrome to determine what to do. And so there's some nuance there, and there's still expertise required in just interpreting this type of test. So those are definitely some issues there. This is how a Carius blood test performs for negative predictive value for pneumocystis or mucor, which is great, 98%. Probable aspergillosis, 72%, not so good. And then this is a paper that was looking at diagnosis of infections, I believe, in immunocompromised patients by usual care, standard of care diagnostics alone versus with the sequencing. And so yellow is usual care alone, and then the blue box is with sequencing. So as you can see, the sequencing didn't pick up everything that usual care did. However, there are a few cases here where you get a little bit of additional diagnostic benefit where the sequencing picked up something that was adjudicated as being real, that standard of care did not pick up. And so there's a little bit of math and philosophy here, but if you're trying to diagnose something that's life-threatening, this is, although the numbers are small, this is an important consideration. So is sequencing on its own, just independently able to include or exclude every type of infection? In the paper I referenced here, the authors concluded that it should not be used independently against all possible invasive fungal diseases or infections in general. And as you can see there, half of the yellow does not overlap with the blue box of the sequencing. So that being said, this doesn't really take into account the combination with other tests. So if you include many of the tests that we've spoken about plus sequencing, I think you can get a relatively good negative predictive value. And it could be used in that sequence in combination with other tests as a way to rule out fungal infection or de-escalate antifungals, for instance. Okay, I'll spend just a little bit talking about maybe the future. We'll see. This is not ready for prime time yet, but it's in development. There's something called host response profiling. So this was an article where basically there's a group that took a bunch of people with CNS infections, meningitis, encephalitis, et cetera, and they knew, what type of infection they had. It was a bacterial, fungal, viral, autoimmune, which is not an infection, but auto-inflammatory encephalitis. And so what they did is they did gene expression profiling on stored samples from these patients, and they looked to see were there gene expression signatures that could differentiate between the type or the cause of meningitis or encephalitis, and they actually found that there were. And so again, I don't think this is commercially available yet. Maybe in the future it will be. But think about the ability to determine what class of organism is causing CNS inflammation, or if it's non-infectious, and how that can work to help someone get off of vanc, ceftriaxone, ampicillin, voriconazole, Bactrim, et cetera. So this could be something very interesting for the future. So just two last quick slides. So important things to remember that not all pulmonary findings are fungal infections in immunocompromised patients. There's lots of other things that are not fungus that cause pneumonia in an immunocompromised patient. And then additionally, there's lots of things that are not infectious that cause pulmonary findings in any patient, including immunocompromised patients. So always keep a broad differential in mind. Primary teams are always very concerned about fungal pneumonia, and lots of times we find something completely different. And then I'll again just sort of plead to send the right test for the right host. So if you have an immunocompetent long-term smoker with a small spiculated incidentaloma who's asymptomatic, I think it's fine for the proceduralist to just get a biopsy, or if there's something that they have a high concern about, they can send a specific test. But I don't think they need all these tests that we just talked about. But on the flip side, if you have a stem cell transplant with graft versus host disease, which is refractory and they're on multiple immunosuppressants for that, and they have new cavitary lung lesions despite being on posaconazole prophylaxis, you're probably going to need to send a lot of what we just talked about and maybe more. But a lot of the cases are not so obvious and a little bit more nuanced, and so you have to exercise judgment. And so again, if your pretest probability for an invasive fungal infection is extremely low and you're using a very sensitive test, the chances of catching a false positive or colonization are high. And so if you put a patient into a situation where you've told them that they have invasive aspergillosis when that can't really be the case, you're going to expose them to a lot of unnecessary consults, unnecessary medication procedures, costs, and anxiety. So try and nip this in the bud through diagnostic stewardship. Okay. That's about all that I have. So I'll try to answer your question with a question.
How do you, good presentation, thank you.
Thank you.
How do you differentiate when a patient is colonized as opposed to injured? sometimes overuse of antibiotics also could lead to Candida, yeast colonization. How do you differentiate?
Yeah.
For example, upper respiratory culture, for example.
So if with Canada on an upper respiratory culture, the things that would be concerned about, where that would be something that I might want to treat, would be very, very few. So if you have someone, and it depends sort of on the clinical scenario. So and the chest imaging is really important. So if you can have septic emboli with Canada, where that can show up in the respiratory culture, that's something that you would treat. You can have a pleural effusion, like from aspiration, with Candida, where that will also be in the respiratory culture. That's something that you would treat, would be a Candida empyema. And then there's something that's very rare, which is Candida tracheobronchitis, which is essentially similar to Aspergillus tracheobronchitis, where you see kind of plaques throughout the cartilage. You need to really a bronchoscopy or a laryngoscopy to diagnose that. Those are really the only three scenarios where I would worry about Canada and the upper respiratory culture. Outside of that, I generally don't. But for generally speaking, when we find mold or when we find other types of fungus in the respiratory culture, we have to get back to sort of the beginning of the talk with what's the host? Is this someone who is at risk of this type of infection? And then what's the clinical factor? So that's generally speaking, what does their chest radiography look like? So, if they have nodules or cavitary lesions that are otherwise unexplained, that would be very concerning for a mold or an endemic mycosis, for instance. But there's only certain patients who will get those things. And so you kind of need to put the clinical radiographic factor together with what you're seeing from the lab data. Mm.
Very invasive. That's probably was the reason that you were told to not be invasive. But could you just have a few bars about when you do get invasive and when you can't really use these diagnostic things and you actually need tissue or something more invasive?
Yeah, so I mean, we're trying more and more and more to avoid biopsies for our patients. I mean, we've always had sort of a hard time with patients who have severe thrombocytopenia or elevated oxygen requirements about getting a bronchoscopy, for instance. And so we have found that some of these tests are ways to kind of get around some of those more invasive tests with bleeding risks. There are times when all of this testing comes out negative, and we kind of have to think, okay, what else could be going on? In which case, getting something histopathologically confirmed is helpful. So some of the things that we found that we think are fungal pneumonia, for instance, but are not, have come out of actually doing the lung biopsy, the wedge resection, the bronch biopsy, and those are things like organizing pneumonia or like a pulmonary toxicity from a drug. So there's still a role for biopsies, but we're trying to I think to minimize them as much as possible for various reasons. Yeah.
Just in these very complex patients, and you're trying in your role as antimicrobial stewardship person to de-escalate antimicrobials, if all the testing does point to, we can de-escalate, what is the most effective method that you have found to do so with meat testing providers?
Yeah, I think it's hard, right? Because there's a question that comes up about whether or not you can do stewardship in severely immunocompromised patients because there's sometimes competing interests with what the primary team feels are the health of their transplant program, things like that, and anxiety and lack of knowledge. And so, I think having a good relationship with those primary services, doing handshake stewardship in some instances is kind of what's needed to longitudinally earn trust. Walking primary services through the decision making and saying, we feel confident that these things have been excluded. And so we can kind of cone down on the one thing that we found. We don't think that there's multiple things that are causing this lung nodule. It requires a delicate touch, or sometimes more than delicate touch. But it's difficult. But yeah.
Talk about stewardship beginning from the lab to the moment. Can you just expand on that a little bit and what you see maybe the role of the epidemiologists that receive the lab sometimes when we do work on epidermis cases? Can you touch on that and how we can try to give our opinion?
Yeah, so I don't have that epi lens personally. So but it's like I said, it's important to send sort of the right test for the right patient. And so it may be helpful when Candida auris is sort of its own beast, but when samples are being sent off to the health department, it may be important to sort of characterize what the site of the sample is, and what sort of the clinical scenario is happening at that time, so we can sort of make sense of it. And yeah.